The topic of cranial is all about understanding the motion of two bones in relation to one another. It's usually difficult for students because there's a lot of 3D spatial awareness. But what I've done in this lecture is broken down these complex 3D motions into 2D structures that you can easily identify. So to first go over it, here's a picture of the two bones that we're talking about from a side view. Here's where the sphenoid is. Here's the occiput, and here is the SBS joint, or the spheno-basilar synchondrosis. This joint is what we're going to be naming all the dysfunctions of. From a top-down view, here is where the sphenoid is, here's where the occiput is, and here is that SBS joint. Remember, the SBS joint is the articulation between the sphenoid and the occiput where all motion rotates around. So to start off with, we're going to talk about how you can palpate these motions using the vault hold. The vault hold is going to tell you where you are going to hold your fingers in order to palpate the motion. Your index finger will be at the greater wing of the sphenoid. Your middle finger will be located on the temporal bone in front of the ear. Your ring finger will also be located on the temporal bone in the mastoid area. And your little finger will be on the squamous portion of the occiput. The main 2 points for you to get the diagnosis will be the index finger and the little finger. The index finger is palpating the motion of the sphenoid, and the little finger is palpating the motion of the occiput. So now I'm going to draw out the SBS joint, where the spheno-basilar synchondrosis is, and how the sphenoid and occiput relate to one another from 3 views. A view from the side, a view top down, and a view from the posterior view. So throughout all of these drawings, we're going to have the sphenoid in red and the occiput in blue. For a top-down view, you're going to see this, where red is sphenoid, blue is occiput. And from a posterior to anterior view, you'll see this, where the 2 wings of the sphenoid are both level. So the 2 primary motions of the SBS are going to be flexion and extension. During flexion, the sphenoid and the occiput rotate outward. Now recall from the sacrum video, we had mentioned craniosacral motion along with nutation and counternutation. When the SBS goes into flexion, the sacrum is going to move into counternutation. The sacrum will be pulled back posterior. The way you can think of this is as if there is a line that attaches the occiput to the top of the sacrum. So when the occiput rotates outward, it's going to tug the sacrum back up with it and dip it into counter nutation. When you go into flexion, you are going to have a short AP axis a wide transverse axis and your sacrum will counternutate. The next motion is extension. Extension is the motion that's going to happen after flexion. Extension will bring the sphenoid and the occiput back to neutral. So it's going to look like this. So the occiput will rotate back down and the sphenoid will rotate back down. So the sphenoid and occiput are already in flexion. They're going to make this rotational movement to return back to neutral, and that movement is extension. When they make this movement, it's also going to move the sacrum. Now you still have that string that's on the sacrum. When the occiput rotates back down into neutral, the sacrum will then dip into nutation forward. So during extension, you're going to have a long AP axis, a narrow transverse axis, and your sacrum will nutate. So what about the rest of the cranial bones? During flexion, all other paired cranial bones will externally rotate. During extension, all paired cranial bones will internally rotate. This motion is what causes your short and long AP axis and your wide and narrow transverse axis. So now we're going to talk about dysfunctional motion and some different diagnoses that you can have in the world of cranial. So our first one is going to be a torsion. So here's what a drawing would look like from the posterior view. You have your occiput, and then you have your sphenoid. The motion that's occurring here is a twisting motion along an AP axis. Now the twisting motion is going to be different for the sphenoid and the occiput. Imagine that this hand is for the sphenoid and this one is for the occiput. While one hand rotates to the left, the other hand will rotate to the right. So this is the motion of a torsion from the posterior view. So here, the sphenoid is rotating to the left, while the occiput is rotating to the right. This motion occurs around an AP axis, and the motion is opposite of one another. So how do you name this dysfunction? You're going to name it based on which wing of the sphenoid is more superior. So in this drawing, the right wing is more superior, so you have a right torsion. The second diagnosis that we're going to go over is a side bending and rotation. For this dysfunction, we're going to have the occiput and the sphenoid from a posterior view, except this time they both rotate in the same direction. So they both rotate to the left, or they both rotate to the right along an AP axis. But there's also a second motion that happens. What happens here is there's rotation about two vertical axes where they both rotate in opposite directions. So the sphenoid is rotating counterclockwise while the occiput is rotating clockwise. You're going to name this dysfunction based on which direction the sphenoid is rotating. So the sphenoid is rotating to the right, so this is a right side bending and rotation dysfunction. We discussed the rotation around the AP axis, and they both rotate in the same direction. The rotation along the two vertical axes are in opposite directions. So there are three axes that side bending and rotation dysfunctions occur around. There's the AP axis, where both bones rotate in the same direction, and then two vertical AP axes where they both rotate in the opposite direction. The next three dysfunctions are going to be something that you see in trauma patients. So the first one is going to be a shear. In this dysfunction, one bone is going to be rotated higher than the other. So the sphenoid will be rotating superiorly, while the occiput is rotating inferiorly. To name the dysfunction, you name which direction the sphenoid is rotating. So the sphenoid is rotating up, so this is a up shear. Or a superior shear. There are two axes that the bones rotate around, and they are both horizontal. So imagine the two axes are here and here, and both bones are rotating around the axes. Both bones are rotating in the same direction. In this example, they're both rotating counterclockwise. So in this example, you have an up shear or a vertical shear. The next dysfunction is lateral. And here you have the sphenoid and the occiput moving laterally in two different directions. The sphenoid moving right, the occiput moving left. You're going to name the dysfunction based on the direction the sphenoid is moving. The sphenoid is moving to the right, so we're going to name this right lateral. The final dysfunction that you may see is a compression dysfunction. In this dysfunction, both bones are coming together. So at the SBS, they're both compressing, so a compression dysfunction. So what are the indications that you're going to need to see in order to assess the patient for a cranial dysfunction? It can really be just about anything. So if the patient comes in and he's just saying, I don't feel so great, I'm tired, I have a headache, whatever, you can assess for cranial dysfunctions. If you're going to treat cranial, your treatment pattern will be indirect. So remember, for indirect treatments, you push into the freedom, or what they can do, or into the diagnosis. So if I want to treat a right torsion, I'm going to push the bones further into right torsion. So it's an indirect technique. The way that you're going to do this technique is with your fingers still in the vault hold and by moving into that motion. Two other techniques that you need to know the names of are CV4 and the V spread. So a CV4 treatment is going to increase the patient's CRI, or cranial rhythmic impulse. A normal CRI is 8 to 12 per minute. If you want to increase the CRI, perform a CV4. V-spread is going to help you release sutures. When you release the sutures, you're going to have more motion at whatever suture you're treating. So we went over how to represent all of these dysfunctions pictorially, but what are you going to palpate when you're palpating the patient's cranium? So you have your fingers in the vault hold. You're going to have your pointers on the greater wing of the sphenoid and your little fingers on the squamous portion of the occiput. During flexion, you're going to feel both hands move towards the patient's feet while your fingers spread apart. So normal flexion will look like this, and this is what you will palpate. Extension is going to bring you back to neutral. So once you're in flexion, extension will feel like this. Your fingers are going to come back where they started, and your pointer and pinky are going to come closer together. So flexion and extension. What about a torsion? When you're palpating a torsion, you always want to name based off whatever wing of the sphenoid is more superior. When you're doing this palpation, a torsion will feel like this motion. You're going to name it based on which wing of the sphenoid is more superior and which finger is palpating that, your pointer fingers. So if we're going to name a right torsion, the right pointer finger will be higher than the left. So right torsion, left torsion. What about side bending and rotation? Exaggerate the flexion and extension motions, just do them backwards. So one hand will go into flexion and the other hand will exaggerate into extension. Going the other direction, it will look like this, where one hand goes into the flexion motion and the other hand comes back and into exaggerated extension. You're going to name the dysfunction based on which hand goes further into flexion. So this will be a left side bending and rotation. Shears, your fingers will move in this direction. This will be an up shear. Up shear will move like this. A lateral strain is the parallelogram head that you remember from class. So you're going to feel this motion where the fingers move into a parallelogram. You're going to name it based on which direction your pointer fingers are both going. So a right lateral shear, left lateral shear. So if you remember the hand motions as well as the pictures that we've drawn, you should be really prepared for any cranial that comes up on your exams or even in the clinic. And that is OMM cranial.